Everybody, my name is Pradeep Ramalu. I'm an Associate Professor of Ophthalmology at the Johns Hopkins Wilmer Eye Institute, and I'll be lecturing on the behalf of MediTred and Dr. Ayala regarding secondary angle closure glaucomas. The date today is November 6, 2014. I think there's some truths about all secondary glaucomas that I think that cut across each of the individual diseases that we'll talk about today. The first is that all of them are high-pressure glaucomas. And indeed, we don't necessarily wait until there's actually glaucoma in the setting of optic nerve damage and visual field loss with these conditions. Rather, the onset of high pressure as a result of the mechanisms that we'll discuss today often produce the diagnosis of glaucoma, whether or not there's actually been vision loss related to the optic nerve damage from this high pressure. All of them result from impaired outflow of the aqueous humor, although as we'll see, you need to think through how does aqueous humor normally flow out of the eye, and at what point is this outflow impaired. And when one thinks about this, you can really think about how the secondary glaucoma is producing its elevation of intraocular pressure, and either the potential for or frank glaucoma. If you look at the normal, angle, the fluid is formed by the ciliary body behind the lens. And once you go from behind the lens, it passes through a very narrow channel between the lens and the iris and comes into the anterior chamber. When it comes into the anterior chamber, it has to cross through the trabecular meshwork, and it exits through the episcleral veins. So there's many places at which this can be blocked, and we'll go through each of those individually in the next slide. So first of all, it can happen in the context of an open angle, meaning that there's nothing physically blocking access to the trabecular meshwork, and we won't talk about that today. Or it can happen in the setting of a closed angle, where the iris has now come up against the trabecular meshwork, and this can either be because the iris is being pulled forwards, usually from some sort of fibrotic response that causes it to fibrose and zip shut with the trabecular meshwork, or because there's something posteriorly pushing it closed. For example, in primary open-angle closure glaucoma, it's simply the aqueous in the posterior chamber which pushes the iris forwards because of a high resistance at the iris lens channel. You really need to think about where the normal pathway for aqueous is blocked with all of these secondary glaucomas. When you think about an open angle, which we won't talk about today, the general areas where you can have outflow obstruction are either just prior to the meshwork, for example, if you have a hyphema, within the meshwork itself, either as a result of changes in the connective tissue from steroids or from trauma, or distal to the trabecular meshwork in Schlemm's canal, for example, with elevated episcleral venous pressure seen in Sturge-Weber. With closed-angle glaucoma, there's probably four major areas where things can become obstructed, where you can generate this iris trabecular touch. First of all, you can have a rotation or expansion of the ciliary body. So this is what happens in the context of choroidal effusions, for example, that happens as a result of some medications that are used, or from tumors or cysts, or from suprachoroidal hemorrhage. It could also happen with choroidal detachment, although for other reasons, which we won't get into so much today, the pressure tends to stay low in that situation. It can happen in ciliary block, also known as aqueous misdirection or malignant glaucoma. And one mechanism for this, for example, is when there's a very large lens, for example, the oversized IOLs that were placed in the eye historically, which can actually cause cilio-lenticular touch and then cause more fluid to flow posteriorly as opposed to anteriorly. You can get pupillary block. This is what happens not only in primary angle closure glaucoma, but in several other conditions, including uveitis, where you can get iris bombay, silicone oil, or a dislocated IOL or an AC-IOL. And finally, as we mentioned, you can actually have scarring of the angle shut, either in the setting of neovascular glaucoma, uveitis, or chronic primary angle closure glaucoma. So just to review the mechanism again, the angle can be pulled closed or pushed closed. And if it's pushed closed, it can either be by fluid, either at the level of the pupil or the level of the ciliary body, or it can be as a result of the ciliary body itself. It can be, for example, because of tumors or cysts, it can be swelling of the ciliary body, or it can be an anterior position of the ciliary body, which is what we see, for example, in Plateau Iris configuration, which probably accounts for a significant amount of angle closure. When you trace the pathway of aqueous obstruction, the ciliary body, you see that it has to first pass through kind of a virtual channel from the
call from Walgreens.
I'm going to start this slide again, and then hopefully you can edit again afterwards. When you trace the path of aqueous fluid coming from the ciliary body, the first potential area for obstruction is before it even gets into.
For using Walgreens Pharmacy. Look.
Sorry, I'm going to try and start this slide one more time. So when you trace the pathway of aqueous humor from the ciliary body through to the trabecular meshwork, the first place that it can get obstructed is right when it leaves the ciliary body. In other words, it can be kind of redirected somewhat posteriorly, and this is one of the mechanisms that's been put forth for this condition known as aqueous misdirection or malignant glaucoma. This condition has a lot of names, probably because its etiology is not very clearly delineated. So the most common name or historical name has been malignant glaucoma. It's an old term, and it was introduced originally because these eyes were first treated with surgical iridotomy, but then afterwards surgical iridotomy did not cure the elevation of intraocular pressure, and so therefore it was called malignant, meaning that it was hard to treat. It's also been known as ciliary block glaucoma. This is the idea that for example, an a large IOL or a native IOL may actually touch the ciliary body itself, and instead of fluid flowing from the ciliary body into the posterior chamber of the eye, it actually flows back into the vitreous. And more recently, the term aqueous misdirection has come about, and it suggests that aqueous humor is being redirected through into the vitreous, which then pushes the lens forward and the angle closed, and there probably is some truth to this. I'm going to go back and forth using the two terms for this because I know that there's a lot of controversy about the naming of this condition, and I think that's not our purpose to necessarily understand the naming, but rather to understand the condition itself. The risk factors for this are first and foremost angle closure glaucoma, and you need to think about this complication whenever you operate on an angle closure eye. This may be simply because the eye is very crowded. So for example, if you consider the ciliary block mechanism that we just discussed, it may be that in a crowded eye there's not as much space between the ciliary body processes and the lens itself, and so there's more potential for those to touch or be in close contact, which would lead to a relative posterior flow of aqueous humor. This is a complication which typically happens after surgery. There are a few reports of it happening after simply medication use, particularly pilocarpine, but most often it happens after cataract extraction, trabeculectomy, tube shunts, or sometimes even laser procedures such as laser iridotomy. It doesn't happen right away. It's going to happen days or sometimes even weeks or months after the procedure. I think the classic finding is that what we call axial shallowing of the anterior chamber. So for example, it may not simply be that the peripheral anterior chamber is shallow, but rather that the central anterior chamber is very shallow. It's as if the entire lens has been pushed forwards. The intraocular pressure is high, but it's not necessarily very high. I wrote here high teens and up, but even that is not completely true. If you have a intraocular pressure which is even 10 or 12, malignant glaucoma needs to be in the differential. Of course, the angle will be closed, the central anterior chamber will be shallow, and sometimes the pressure will be very high, in which case you might get nonspecific features which are associated with elevated intraocular pressure, such as a cloudy cornea, pain, lower vision, halos, nausea, etc. This is a picture of the central anterior chamber. So here you have a slit beam that shows even, not right in the center, but we're quite close to the center, or right at the edge of the pupil, and you can see the anterior chamber is very, very shallow, much beyond what you would ever see in, say, for example, just a primary angle closure eye. So what are the mechanism that's happening over here? Well, there's probably several, and our treatment has to relate to all of these as well. So the ciliary body is probably swelling, and rotating anteriorly. So probably what we want to do is we want to rotate the ciliary body posteriorly, for example, with cycloplegics. There's a lot of vitreous pressure coming forward. It's probably the one thing that everybody agrees upon with regards to the mechanism of the disease is that when you get this flow of fluid through the vitreous, that this increased flow of fluid tends to cause the vitreous to be very, very compact and condensed. And once it becomes condensed like that, it tends to become very impermeable to fluid. So whatever fluid that continues to go into the vitreous has a hard trouble getting out, and as a result, the entire vitreous is pushed forwards. The analogy that I like to use for those of you who have done intraocular surgery is when you hydrate Tenon's capsule. So for example, if you are trying to do a subtenon's block or you're infusing mitomycin as part of a trabeculectomy, if you inject balanced salt solution or another solution into the tenons, it'll rapidly hydrate, and then suddenly it will become much more impermeable to fluid. So its properties change. So I think the same thing is happening here, that when a lot of fluid flows through the vitreous, it becomes relatively impermeable to fluid flowing through it, and then whatever fluid is there has a hard time getting out, and it just tends to push the whole vitreous face forwards rather than going anywhere. The result of that is the whole lens and zonules and iris coming forwards, and then that takes the lens forward and it pushes the iris forwards as well, so that the entire anterior chamber is collapsed. There's probably three parts of the disease, each of which we need to consider. First of all, the question is, well, why does it happen? Nobody really knows for sure. There's been a lot of theories put forwards. One idea is that the vitreous comes forward as a result, for example, of a sudden drop in the intraocular pressure. And now there is either touch of the lens and the ciliary body, or now the anterior hyaloid touches the ciliary body. So now there's a relative block of fluid coming forward into the posterior chamber, and rather there's a disproportionate amount of aqueous humor which gets redirected into the vitreous cavity. Once that it happens, you can say, well, why does it continue to happen? And this is a question which I think is quite mysterious. So certainly if a little extra fluid goes into the vitreous, normally aqueous humor is hydrating the vitreous. So why does it continue to hydrate it, and why does it become kind of overhydrated or kind of chronically overhydrated? Well, it's not really clear. It may be that a temporary increase in the rate of fluid that goes through there causes these vitreous changes that I was talking about earlier, such that the entire vitreous is condensed, or where the vitreous just next to the anterior hyaloid is condensed. It could be that somewhat permanent adhesions occur, either between the vitreous and the ciliary body, or between the lens and the ciliary body. Or it could be that there's some sort of ball valve mechanism that's formed, which actually does misdirect aqueous in a more chronic fashion. This is a diagram which describes the treatment options for this. It doesn't really list all of them, although I'll mention a couple that aren't even on this. There's certainly a lot of laser or surgical treatments that have been discussed. People have discussed it. If you can actually see the ciliary bodies, you can treat them with an argon laser that shrinks them, and people have seen resolution of malignant glaucoma from this alone. If it doesn't resolve, the other laser therapy you can consider, based on the patient's lens status, is that if they're pseudophakic, you can consider a YAG anterior hyaloidotomy. So this is like doing a YAG posterior capsulotomy, except you focus even more posteriorly, and then you can try and focus on this thickened anterior hyaloid, and if you break a hole in that, you might actually resolve this whole episode. If it doesn't work, or if the patient is phakic, then usually you're going to be considering going straight to the emergency room, assuming that medical treatment with cycloplegia and steroids hasn't worked. And then in the surgery, we'll discuss what that surgery ought to be, but typically you really want to make the eye unicameral, meaning that you want to make it one chamber. So you want to remove the vitreous, you want to remove a bit of the iris, you want to move the zonules behind it, and you want to make sure that you disrupt the hyaloid. If you don't cut any of those, then it's possible that people will come back into malignant glaucoma again afterwards. And indeed, I've seen people who've had a vitrectomy, but the retinal surgeon was not fastidious about making a hyaloidectomy as well, and the patient comes back with malignant glaucoma 1 or sometimes even 2 times. Of course, if somebody is phakic during this, you're probably going to need to do a lens extraction as well. And you can either have the retinal surgeon do that, and you can put in a sulcus IOL, or you can do a combined procedure where you might do that yourself. The other treatment which I must mention does work fairly well is diode laser, and there are some good studies which suggest that diode laser, which probably shrinks the ciliary processes, can be quite an effective therapy. Of note, there is one recent paper from about a year and a half ago which describes the success of all treatments aside from diode laser and found that medical treatment, YAG hyaloidotomy, and cycloplegia all were very ineffective at being successful long-term in terms of lowering the intraocular pressure. And really, the only thing that was a good definitive solution was pars plana vitrectomy with Zonulo-hyaloido-vitrectomy. So this kind of recapitulates or talks about the treatments again and shows them, what exactly are you doing. You can treat the ciliary body, where you can shrink the ciliary processes, which presumably are causing part of this block. You can either cycloplegia. In cycloplegia, you're also rotating the ciliary body backwards. With direct laser or with diode laser, you're shrinking these processes. You can treat the anterior hyaloid with the YAG laser, and you can remove the vitreous body, or you can just simply disrupt it, which is called the Chandler procedure. I don't think this is done anymore, but this is where you make you put a needle into the vitreous and you simply move it around to disrupt the vitreous. Of course, this doesn't disrupt the anterior hyaloid, so it's going to be much less effective. People have also simply done cataract removal and with an anterior approach, done a Zonulo-hyaloido-vitrectomy. You can either do this anteriorly, coming through the iris and the zonules after you put in your IOL, hopefully, or you can actually come in more posteriorly, so make a pars plana incision and then come to the far side of the lens and come through the zonules and the iris at that point in time. Ideally, you would constrict the pupil otherwise. Constrict the pupil before you do this, otherwise you're going to get a very large iridectomy. I tend not to do this. I tend to prefer to have a retinal surgeon remove the vitreous entirely, just because I do think that is the most definitive solution. And typically, these are eyes that you don't want to be operating on multiple times. This is a demonstration of pre and post YAG. You can see prior to YAG, there's a very shallow anterior chamber, and after YAG, the chamber has deepened considerably. This is a tough diagnosis to make, and this is a common question that I give our residents during their mock oral exams. And I think they often struggle with understanding everything that's the differential and what you have to exclude to come to a diagnosis of malignant glaucoma. First of all, you have to consider other things that might cause a high IOP, and you really can't completely rule out the things that might cause a low or low normal IOP, since malignant glaucoma doesn't always raise the pressure that much. The things that are in the differential for a high pressure shallow chamber glaucoma are suprachoroidal hemorrhage. This will usually have very severe pain and will have a sudden onset. You have to think about eyes that might be at a risk for this, such as elderly eyes, people with hypertension, particularly hypertension that's not well controlled, people who have a sudden decompression of the eye. You can usually see this as kind of a reddish tinged choroidals on fundus exam, or if you can't see the fundus because of high pressure and cloudy cornea, you can get a B-scan ultrasound to rule that out. You want to make sure this is not just simply ciliary body edema or rotation. This again can have a normal or high IOP. This usually tends to occur in specific situations, for example, posterior scleritis or VKH or medication use. But it can happen after procedures, including after LPI or panretinal photocoagulation of scleral buckles. Again, this is usually something which you can rule out by a good history, or you might want to do a UVM to actually look at this as well. Pupillary block can cause kind of a more of an iris Bombay configuration, although if there's a lot of separate attachments between the lens and the iris, then you could have issues with that. And then sometimes you don't get a frank Bombay, but you kind of get partial Bombay, if that makes any sense. Of course, you've already usually ruled this out, because typically malignant glaucoma occurs after trabeculectomy or after cataract extraction. And each of those procedures already remove pupillary block, either by removing the lens, removing a portion of iris, or both. Choroidal detachment can sometimes mimic malignant glaucoma, especially these annular choroidals, which occur in the very far periphery of the retina and cause a very shallow chamber with a high pressure. So these are very difficult to detect. So you really have to have the patient look way to the side and look well out to the periphery to see them. You can try seeing them on a B scan, but even a B scan can miss them because they're so far out in the periphery. So you really have to be vigilant to see these, and sometimes even consider a UVM if you have access to one. Overfiltration and wound leak are probably less likely to be in the differential because typically the pressure will be in the single digits or usually the low single digits, and you'll be able to find that. The next category of secondary angle closure glaucoma that we'll talk about are ones that relate to pupillary block, although we won't discuss the most common one because it's not a secondary glaucoma, it's a primary glaucoma, specifically primary angle closure glaucoma. If you want to think about pupillary block, you need to think of it by lens status because the lens is the most common thing which is going to block the pupil, although it's certainly not the only thing. So if somebody's phakic, the lens itself can be large or anterior, or be found in the setting of a crowded eye, which is primary angle closure, or primary angle closure glaucoma if it's caused enough damage. You could also have the, instead of just simply having a high resistance, because the two are in close proximity, the two being the lens and the iris, you can actually have them physically attached as a result of posterior synechial, in other words, attachments between the iris and the lens. And this will actually cause the iris to really bow forwards as like a sail, which is known as iris bombay. The lens can also come out of its normal place or have an abnormal shape. So this can happen in the setting of Marfan's or in Weil Marchesani, where the lens is not only prone to subluxation, but it's also kind of smaller and more spherical. It can also happen in the setting of trauma. Phakic eyes can also have other things which block the pupil, and that other thing is most commonly a hyphema. So in fact, we think of a hyphema blocking the angle, but actually the reason that large hyphemas are a problem is that they block the pupil. So the fluid can come forwards between the iris and the lens because there's so much blood in the anterior chamber, and this is what's happening in an 8-ball hyphema. So actually the treatment for that is, what we often do here is what we call an orphan trabeculectomy. But you're really not doing a trabeculectomy. You're really doing a large iridectomy and eliminating that pupillary block. If somebody's pseudophakic, you can still get pupillary block as a result of the lens. So, for example, with an ACIOL, as that happened as a result of complicated cataract surgery or cataract surgery in which there was insufficient zonular support to put in a lens, you can certainly get pupillary block, particularly if the surgeon was not wise enough to do a iridectomy at the time of surgery. PCIOLs can also be dislocated as a result of trauma, pseudoexfoliation, other conditions which cause weak zonules such as aniridia. Even in an eye without a lens, you can have things that block the pupil. So for example, silicone oil can form a seal against the pupil, or a gas bubble used as part of retinal detachment repair can form a seal against the pupil as well. So we'll first talk about pupillary block by the lens. So this is typically where now the lens is coming very close to the iris. The resistance between the iris and the lens is very high, so the pressure in the posterior chamber is high, and it pushes the iris forwards and causes the iris to abut the trabecular meshwork, which in some cases can cause the intraocular pressure to go high. There are several secondary conditions which allow this to happen. Weil Marchesani is characterized by a small spherical lens, which is prone to movement. Since the lens is spherical, the eye is often myopic, even though it presents with angle closure. So this is a good board question. So if you see a myopic eye with angle closure, what secondary glaucoma do you need to think of? And the answer is microspherophakia or Weil Marchesani. They do have some systemic findings. They're shorter. They have extra fingers sometimes. They can have very stiff. They can have brachiodactyly. I'm sorry, not extra fingers. And they can have joint stiffness as well. Marfan's is kind of the opposite condition. They tend to be tall. They tend to have very flexible joints. They have a pectus excavatum. They also have cardiac conditions such as aortic dilatation or aneurysm. They have myopia, but not from the lens, but from the eye itself being long, and they can get cataracts from this as well. This is typically an inherited condition as a result of fibrillin mutations, and so it's important to ask about a family history. Homocystinuria is less common. It's, again, very similar to Marfan's in terms of a lot of the phenotypic findings, although they tend to have tighter joints, and it's a recessive condition as opposed to Marfan's, which is dominant. This shows pupillary block from an anterior chamber intraocular lens, and you can see, while here the pupil is dilated, which allows some fluid to be coming right up against coming around the edge of the lens. If the pupil were not dilated, it would be very difficult for fluid to get through. So one option in the acute setting here is to dilate the pupil to try and get the iris to dilate past the edge of the IOL and break that acute attack. And then once the patient is out of the acute attack, you can go back and you can do an iridotomy when they're more comfortable. There's many other lens-induced glaucomas, and each of them has kind of developed its own name, which I think is probably unfortunate, since they're generally all treated fairly similarly, and the nomenclature really gives you very little input about what is actually happening in terms of the mechanism. So primary angle closure glaucoma is a lens-induced glaucoma, although we certainly don't think of it that way. And indeed, there's growing evidence that lens removal can play a very important role in our treatment of the condition. Phacomorphic glaucoma is very confusing because really I see it as a continuum of primary angle closure glaucoma. It comes from an unusually large or intumescent lens, but unlike primary angle closure glaucoma, usually this lens has enlarged fairly quickly or acutely or subacutely. Of course, this is often hard to tell. What did this lens look like 6 months ago, or what was it like now? But typically, the patient may describe, relatively good vision in the eye up until a couple months ago, and then suddenly the vision deteriorated quite quickly, and they started developing these attacks of pain, which presumably were due to elevated intraocular pressure, and probably you might have documented one of these when you first saw the patient. So it kind of talks about the time course, but ultimately it doesn't really change things very much. There's also various things that can cause lens material that's not the whole lens to cause glaucoma as well. So fragments either can directly or indirectly cause inflammation, which elevates the intraocular pressure. Phacoanaphylactic glaucoma is characterized by keratotic precipitates and granulomatous inflammation after either surgery or trauma, often for example, from a retained lens fragment. Phacolytic glaucoma is usually when you have a hypermature lens and some of that lens protein leaks through the capsule, which causes inflammation characterized by macrophages in the trabecular meshwork. Ultimately, the treatment for all of these is to remove the lens, and so even if you don't understand all these terms, the answer of what you do is to remove the lens or what remains of the lens. Well, now that you have pupillary block, what are your treatments going to be? I think, well, the classic treatment, at least for primary angle closure glaucoma, is laser iridotomy. So here, because you've blocked fluid at the pupil, you've created a disparate pressure between the posterior chamber and the anterior chamber, and so you're essentially normalizing that pressure. I often talk to patients about poking a hole in the sail being the iris. Where can you do it? Pretty much anywhere works, especially in this acute setting. Oftentimes, the iris will be right up against the cornea more posteriorly, and so you're going to be forced to come into the mid or even more central iris in order to stay away from areas with frank iridocorneal touch. If you, in the setting of silicone oil pupillary block, you do want to put it in. You want to put your iridotomy inferiorly. Otherwise, a superior iridotomy may cause oil that floats upwards and after coming into the anterior chamber to actually block that iridotomy. I think the key treatment for pupillary block is to remove whatever is causing the block. So if in PACG, one of the things that causes the block is the native lens. And so the native lens can be removed. If it's a dislocated lens, you may want to remove or reposition that lens. If it's a dislocated intraocular lens, you can remove or replace that. If it's silicone oil, you have to consider if it's safe from a retina perspective to remove the silicone oil. You can also make the pupil bigger, which means that whatever is blocking it may be less likely to do so. So this works particularly well if you're dilating past a small object, for example, a PCIOL or a microspherophakic lens. It doesn't work so well if you're dilating around a very large object, for example, native lens or very large silicone oil bubble. It may also not work very well if the IOP is extremely high, as the ischemic iris is much less likely to have enough blood flow to even allow the musculature to respond to the stimulation that you're giving it as a result of your medications. So finally, you can have no block at the level of the ciliary body or no block at the level of the iris lens junction, but you can have the iris blocking the trabecular meshwork directly, and we'll talk about a couple of different conditions which can do this. So this is now, we've kind of gone through some of these conditions, but now we're going to talk about specifically the iris being pushed closed from the ciliary body. And there's three conditions that we'll talk about: either an anterior ciliary body position, swelling or anterior rotation of the ciliary body, or the presence of tumors or cysts. So a plateau configuration of the iris resulting from the ciliary body processes just pushing the iris forwards can cause the angle to be closed. This is something which we talk about very frequently in the context of persistent appositional closure after laser iridotomy. This is probably a continuation of what is normal. In fact, a third of eyes that have a laser iridotomy will have persistent appositional closure afterwards, and this may or may not improve after cataract extraction, because it's not really the lens itself that's the problem. It's actually the ciliary process which is the problem. Laser iridoplasty can be considered in these situations and may actually prevent future IOP elevation, which could lead to definitive glaucoma. You see this in about a third of eyes, and typically if you're doing this in the setting of suspect primary angle closure, the intraocular pressure can still be normal. It's rare for you to actually get glaucoma from this condition, but sometimes you will see that with persistent iridotrabecular contact in the setting of a plateau iris configuration, that you will move on to PAS formation and even frank glaucoma. Some people have suggested that you actually test to see if this is going to happen, or if you test to see whether this plateau configuration is going to be problematic by dilating the patient. And there are a very small number of eyes that have what's called plateau iris syndrome. So not just simply a plateau iris configuration, but a syndrome of the plateau iris, in which case these patients will actually go back into something which looks like an acute attack, despite the presence of a patent peripheral iridotomy. Laser iridoplasty can be used to treat this condition. This is a condition where you actually place laser energy over a broad spot at low energy for a long time into the peripheral iris. What this actually does is it actually recruits iris, it shrinks the iris there, and you can see the adjacent iris kind of moving towards the area of your laser beam. As a result of that, you'll actually kind of get a kind of a thinning of the iris, and you'll actually see the iris sometimes essentially getting sucked or pulled out of the angle as compared to the other side. You can also have ciliary body tumors or iris cysts, which cause a sectoral angle closure. And if you see a sectoral angle closure, you really need to think about this very carefully. This can also move the lens as well, and so oftentimes you'll see a very large and unusual astigmatism. You do want to try and see the tumor if possible. So you want to move your eyepiece of your slit lamp, and then have the patient look to one side and look off to the side, towards the side that you're having them look, with the pupil fully dilated, to see if you can visualize anything unusual. Iris cysts you're probably not going to see this way, but can also cause the same symptoms. Iris cysts are extremely common and probably are present in a majority of people. And so, just because you see an iris cyst doesn't necessarily mean that it's causing it. So you do have to be careful in your interpretation of your results. This is an example of iris cysts on UVM, and I think if you took yourself and your fellow residents, probably one or two of you would have these at least. If you have tumors or cysts, you want to really consider ultrasound biomicroscopy. This is probably the best imaging technique to image this portion of the eye. You really want to see if there's any external feeder vessels on the conjunctival surface. which might be feeding this tumor. Iris cysts can be observed best with UVM, although sometimes you can see them directly or in further presence directly. Tumors, you have to consider what is the tumor in order to decide how to treat it. If it's just a nevus, you want to observe it. If it's a melanoma, you may want to resect it or do plaque therapy. And more aggressive tumors, such as medullary epithelioma, you can even consider a nucleation. Simply choroidal detachments can also push an angle closed as well. So this is when you have either expansion of the choroidal tissue or a frank effusion in the extrachoroidal space. So what are the changes that occur in ciliochoroidal detachment? Well, first the choroid expands, and as a result of expansion, the choroid also tends to rotate anteriorly. And with the choroid expansion, that choroid expansion is transferred to the vitreous, and the vitreous then transfers that to the lens and pushes the lens forward. And so, as a result, the lens moves forward, the ciliary body rotates forwards, and the lens pushes the iris forwards, which closes the angle. So, the things that you'll actually see are frank detachment of the choroid. You can actually sometimes on a gonioscopy see enlarged ciliary processes. You can see a myopic shift sometimes because the lens itself is moving forwards, so it's creating a new focal point anterior to the macula. And you can see a shallowing of the anterior chamber. And finally, with that shallowing of the anterior chamber, you can see a closed angle. And the results of that can be corneal clouding with an elevated IOP. So, well, why do choroidal effusions form in the first place? Typically, you need to have at least two of the three that I've listed here happen in order for this to happen. So, either it can be as a result of changes in vascular permeability of the choroidal vasculature. This can occur from inflammation, such as VKH or scleritis or HIV. It can occur because you've put a lot of energy and disrupted that vasculature directly, for example, as a result of panoretinal photocoagulation. And this is why you don't do 2,000 spots of PRP, that you break it up into multiple sessions. This is probably what is actually happening with certain medications, such as Topamax or other sulfa medications. It actually causes a change in the choroidal vascular permeability. Having too low a pressure in the eye also makes it more likely for fluid to leave from within the choroidal vasculature to outside the choroidal vasculature as well. And finally, normally everybody has a little bit of fluid outside of the choroidal vasculature, and that fluid leaves partially through the wall of the eye. But if the sclera is abnormally thick, for example in anophthalmos or uveal effusion syndrome, or if the little channels around the vortex veins are impaired as a result of a very tight scleral buckle, sometimes that fluid that normally gets out of the choroidal vasculature into the extrachoroidal space just can't leave from that extrachoroidal space. So this shows the suprachoroidal fluidics a little bit better. There is some flow of fluid straight through the sclera, and specifically there's some that flows right around where the vortex veins leave. Additionally, there's reasons that fluid leaves the choroidal vasculature. So there's the things that keep fluid within the choroidal vasculature is the oncotic pressure. In other words, the pressure created by protein within there, which makes fluid want to stay with that protein. The other thing that determines the balance of fluid into and out of any blood vessel, particularly the choroidal vessels, are the hydrostatic pressure. So what is the pressure within the vessel versus the pressure outside the vessel? And so if you lower the pressure outside of the vessel, there's going to be a hydrostatic pressure for fluid to leave the vessel into the suprachoroidal space. So in VKH, Voigt Koyanagi-Harada's disease, or posterior scleritis, you can actually see expansion of the choroid or an even frank fluid there. And you can see a normal AC depth, but you can see the lens moving forwards, which induces a myopia. And if you treat that with steroids, you can actually see the choroid looking normal, and also the myopic shift can resolve. You can also see diffuse choroidal detachment and expansion with Topiramate or Topamax. And this again, if after you stop the medication, goes away. Well, what are the treatments for these conditions? So the best treatment is usually patience. Most of these processes will resolve over a span of days, and the vision is unlikely to deteriorate, especially if the IOP is only high for a few days and hasn't been high in the past. Cycloplegia can help rotate the ciliary body posteriorly and deepen the chamber. Corticosteroids can be given systemically for VKH or other inflammatory conditions. It's not necessarily as effective for idiopathic uveal effusion syndrome, and may not really have a role with improving angle closure. IOP medications can be temporizing, and certainly you're going to try that, although they're often unlikely to lower the IOP significantly. I do consider laser iridoplasty, particularly when patients are uncomfortable or if the pressure is very high, just to kind of get them through this, although sometimes those patients will end up with glare, and the procedure itself can be uncomfortable, so you do have to weigh that against the benefits of the treatment. So now, well, what if you, how can you get blockage of the aqueous leaving the eye right at the level of the iris and trabecular meshwork with really nothing else happening? This is now, we're talking about the iris, the iris being pulled into the trabecular meshwork as a result of conditions such as neovascular glaucoma, uveitis, or eye syndrome. So this typically produces what we call synechial angle closure, where now there's physical attachments between the trabecular meshwork and the iris as a result of whatever the underlying process is. So this is, for example, happening with new blood vessels shown here in red, which form either along the surface of the iris or along in the angle in the peripheral iris. You can certainly look for this, and when you see this, you're going to dub it neovascular glaucoma. Typically, you want to look before they're dilated at the pupillary border, and you'll see very subtle vessels that don't extend all the way to the angle, although these can be hard to see if the pressure is very high, for example, when the cornea is cloudy as a result of high IOP. Gonioscopy, early on, you can see a reddish hue to the trabecular meshwork, and I'll show you an example of that. Later, you'll actually see discrete vessels coming into the angle, and classically, these will cross the scleral spur, identifying them as abnormal. Eventually, these will actually cause the angle to be synechially closed, and when it synechially closes, it's hard to see vessels at all, and in fact, you can't really see any angle structures at all. Of course, you'll want to look at the retina, and you want to see look for evidence of posterior neovascularization, and look for some of the underlying causes such as diabetic retinopathy, proliferative diabetic retinopathy, CRVO, central retinal artery occlusion, or ocular ischemic syndrome, which may not have any posterior findings. This shows the distribution of etiology for neovascular glaucoma. The most common are central retinal vein occlusions and diabetic retinopathy, and less common are carotid occlusive disease or ocular ischemic syndrome and central retinal artery occlusion. This shows kind of a reddish hue to the trabecular meshwork, which can be difficult to see, but you'll really want to think about that and look for that. Usually when you see that reddish hue, you're not simply seeing new blood vessels, but you're seeing a whole fibrovascular membrane, which is why the pressure can be elevated already. You're seeing it right over here. It can be hard to see. This shows, kind of very advanced neovascularization, where now you do see the vessels going all the way across, but this is very, very unusual. The treatment is usually to treat the underlying cause. If you can treat this early enough, sometimes you can normalize the pressure. So you can treat with panoramic photocoagulation, although in the setting of a CRVO, usually you want to wait until the NVI develops, and this was documented as part of the CRVO study. In diabetics, you want to treat proliferative retinopathy with any NVI, and this is really the only definitive treatment available. Even once you do this treatment, however, once the disease has gone this far, it's going to be very, very common for them to go on to develop elevated IOP that's not reversible with just treatment. And so you'll need to follow these eyes very carefully, as they're very likely going to need some sort of surgery to lower the intraocular pressure. Avastin or Lucentis are very good treatments as well. I think they help resolve the blood vessels that are in the angle very quickly. Of course, you have to keep in mind that these are not going to produce a permanent effect, so the underlying ischemia which caused the vessels to form in the first place is going to cause them to form again. And you can use them when the angle is not yet closed, or probably the area where I use them the most is preoperatively in synechial closure to try and prevent your subsequent surgery from resulting in a hyphema, which could really inflame the eye and really lead to significant vision loss temporarily or sometimes even permanently. Eye syndrome is also known as an acronym for iridocorneal endothelial syndrome. This is a unilateral condition usually found in younger females. It causes a beaten bronze appearance to the cornea and causes a variety of iris abnormalities, including high peripheral anterior synechiae, iris atrophy, and polychoria, or multiple pupils. The cornea itself also has distinctive features that result from proliferating, migrating endothelial cells, which actually pull the iris closed. and also can even pull the iris around to cause, for example, ectropion uvea. You can diagnose this with specular microscopy to actually see the abnormal cornea, and you'll see a loss of endothelial cell density and a very typical morphology to the endothelial cells themselves, shown in figure A, as compared to the normal morphology noticed in B. About half of these eyes will go on to glaucoma, and you can treat this with either trabeculectomy or tube shunts. All of these surgeries have a higher than normal failure rate because these proliferating endothelial cells can either block the ostium to the trabeculectomy or even block the opening of the tube shunt as well. Glaucoma can occur at uveitis, either as a result of peripheral anterior synechiae from angle closure, as a result of chronic inflammation. Of course, on the other hand, adequate and aggressive treatment with steroids to prevent this chronic inflammation can cause a steroid response, which can cause glaucoma anyway. And as we mentioned earlier, you can get posterior synechiae from chronic inflammation, which can also cause glaucoma as a result of iris bombae. And this can occur either in phakic or pseudophakic eyes. Once I see that iris bombae, my usual approach is to treat it once with iridotomy, but then really plan to remove the lens and do a huge iridectomy, sometimes even a sector iridectomy, sooner rather than later, because you know that continued inflammation is going to close your initial iridotomy. There are some special cases of uveitic glaucoma as well, although these are more open-angle secondary glaucoma cases. This can be Posner-Schlossman or Fuchs heterochromic iridocyclitis, and these all have their own distinctive features, which you can see over here. So I think this marks the end of our lecture. Thank you for joining me, and I